everyone, and welcome back. I'm Joe Chappelle, and you're listening to episode 60 of the OBGYN podcast. Today, we have a new voice and a new topic. The new voice is Dr. Mariel Gross, and the topic is breastfeeding in HIV-positive women. Dr. Gross is an author on a recent paper on that topic. What really got me interested is that it's not a randomized controlled trial or even a meta-analysis. Rather, it takes the existing data and looks at the question through the lens of bioethics. I really enjoyed this conversation, and I hope you do too. So let's get started with episode 60, The Ethics of Breastfeeding in Women with HIV. Hi everyone, I'm here with Mariel Gross, who is a practicing OBGYN and a fellow at the Berman Institute of Bioethics at Johns Hopkins. Welcome.
Thanks for having me.
So Mariel and I met at the National Perinatal Association meeting, which I've been talking about on the show for a few weeks here. And we had some great conversations surrounding bioethics, and I had a lot of questions for her because it seems like a relatively new field, at least to me, and I didn't know much about it. And it was so interesting that I said, we should come on the show and we should talk about it. She also recently co-authored a paper about the ethics of breastfeeding with HIV. We're going to talk about that as well. But before we get in there, Mariel, I wanted to ask you, how did you get into ethics or bioethics? And as an OBGYN, how did you kind of, I don't want to say fall into what you're doing because it seems like a more proactive thing, but how did you get into this?
Yeah, it started a really long time ago. And I was a pre-med, as a freshman year pre-med undergraduate philosophy major, kind of actually happened as a result of my interest in medicine. I chose to take a bioethics course because to me it seemed relevant to learn some bioethics if I was trying to go into medical school. And that sort of ended up, diving off the deep end of just totally opening my mind to loving to talk about and think about these things that were, the application of philosophy in like real life, specifically in health, and ended up becoming a philosophy major as a result of that. So I switched out of the biology. I actually was simultaneously doing another bachelor's degree in ethics. And I ended up designing the major in Jewish ethics at the Jewish Theological Seminary. And sort of my interest in philosophy and ethics and bioethics kind of went from there. And then I went on actually to do I thought it was so important to stay grounded, this idea of staying grounded in humanity before going into medical training. So I actually ended up doing the bioethics master's degree prior to going to medical school. And I loved I had this like intuitive sense that, when you cut onto a person's body and it becomes rote and in your muscle memory, it's almost like cutting into any other kind of meat. And that freaked me out. And I was like, I really wanted to have this, I think, diverse humanities background that would enable me to really have a firm rooting in the sort of human values as I learned how to treat human bodies in a way that was not necessarily commensurate in certain regards to their humanity. I don't know if that makes sense.
I think it does. We have talked a little bit about on this show about, I think in the last couple episodes, we talked about, I don't call it depersonalization, but definitely, you have to disassociate sometimes between yourself and the patient because what you're doing to them can be relatively horrific. But at the same time,
totally.
It's essential to the care that you have to provide them. And of course, I wish we could provide care that was in a less barbaric way, but it is what it is currently.
Although I would just push back just a tiny bit and say that there's a wide range of latitude that we have in terms of how we practice and our attention to, we don't have to be quite so barbaric in certain ways that are common, I would say.
Okay, fair enough.
We could talk later about Marion Sims and all that, the drama in the background there.
Yes, absolutely. I mean, what I was going to say is OBGYN, I think all of medicine can benefit from a discussion of bioethics or is in kind of engrossed in that topic. But OBGYN, we have even more because we have oftentimes two people who we are caring for. We have a fetus and a mother. And sometimes balancing those two things is difficult. And we're going to get into a couple of those things later when we talk about your paper. But there are some ethical issues that we see there, which can be quite complex, especially if we're trying to impose what our ethics and feelings are on somebody who doesn't have the same notions.
Yeah. Well, it's interesting that you use the word barbaric. I mean, barber was the original surgeon, right?
That's right. Well, and in a lot of ways in OBGYN, we are not that removed from 50 years ago or 100
Totally.
years ago. I mean, we know a lot more about things, but we're still doing C-sections and episiotomies, although we don't really do them where I work, but people do episiotomies, C-sections, forceps. We're not that dissimilar from 100 years ago.
Which is not to change. I mean, I don't want to put the, cart before the horse or anything, but my entire fellowship research focuses on the use of evidence in women's health care. And we'll kind of get to that later. I don't know if, just to give you the rundown of the rest of how I got to where I am. So I sort of approached my medical training with this, intense bioethics and religious background and fully intending to go into medicine. I had nobody in my family that was a physician. And so they kind of tell you as a student, you're either picking surgery or medicine. And I love to think about things and the investigative nature of the kind of medical investigation, and so it seemed like medicine was a natural choice. I was doing research in medical school on the HPV vaccine, trying to increase catch-up vaccination amongst unvaccinated college students in Florida. So I had sort of that experience. I chose for the clinical clerkships, I chose to have my OBGYN rotation last because I thought if there's anything I won't do, in fact, it is that.
That's very common.
I feel like some people come in with an idea that they want to do it, but it is, I think there's a lot of things in our society, culture of medicine and just, the nature of some aspects of our job that are incredibly intimate or overly personal that people would think that they wouldn't want to do. And certainly I felt that way. And I was already applying for my residency in actually a combination. I was very interested in a combination of medicine and preventive medicine. And I took my, GYN, OBGYN rotation at the end of, beginning of fourth year. And I started to be like, this is interesting because I knew so much from the HPV work I had done, HPV vaccine work I had done. I knew a lot about that. And my my master's work had involved a lot of, ethics of IVF and different, things in that field. My undergraduate honors thesis was on the Octomom.
Okay.
And so I knew a lot about these things for some reason. It was just I sort of knew more than I did kind of about sort of naturally about the other fields that I visited on my rotations. And then I went to my first delivery, and it just really struck me how, it was a pair of five. It's like me and the resident running into the room, like catching the baby and watching, wiping it off and handing it back to them.
Yep.
And so it just really struck me how happy of an event that was, and acknowledging fully that all we were doing was at best facilitating a process that was already happening. But at the time I was very interested in HPV and cancer, and I was thinking about, infectious disease and the intersection of infectious disease and oncology, and maybe I will do fellowships in infectious disease and oncology after my preventive medicine fellowship in residency. And, so I'm like coming from that perspective, and I just thought, even if I cured somebody's cancer, I don't think they would have been as happy as that woman was, and all we did was hand her baby. And when you go through, medical school, especially for somebody for me, didn't have any real background in that, we encounter so much suffering and so much heaviness. And there's basically everyone we take care of is worse off than you are. And there's an oppressive feature of that makes the work really oppressive, emotionally, psychologically oppressive. And I was really inspired by this idea that there could be a part of my job that was inherently light and sort of would offset that. And then I started to think, well, wait a second, but then I want to do preventive medicine. Well, a lot of OBGYN seems to be preventive medicine. Right, it should be. And because many women of reproductive age only have an OBGYN if they have a doctor at all. Yep. And then, started reflecting on all of my HPV. Oh, HPV and wait a second, Occam's razor. It would be a lot easier as an OBGYN and more of a direct path to take care of HPV related disease as an OBGYN than as a physician, a preventive medicine, infectious disease oncologist. Absolutely. it like kind of seemed silly that I had. And then when I started thinking about my master's degree work and all of that experience in my Octomom piece, and I was like, it's amazing to me how it was so obvious that it was amazing to me that it had never occurred to me because of my biases about what it meant to be an OBGYN.
I mean, we had an episode 50, where we all talked about how we got into OBGYN, and you basically just told the same story that we all told. We all wanted to do something else, and then did our OBGYN rotation and said, oh my God, this is it. Like, why did I ever want to do anything different? It checks all my boxes for me.
And it's so amazing, too, because I thought that medicine was like the most diverse and broadest field, and I'm a kind of person who has a lot of ideas and gets bored easily, so I like the idea of being able to do all sorts of different kinds of things. And I thought about that, actually OBGYN is more broad because the nature of the work that we do ranges from, psychiatry to surgery and everything in between.
Yep.
And it has so many components of so many other fields in it that we can do more for any one woman than almost any other physician could do for any other patient.
Yeah, I mean, we are basically one of the last general doctors that exist. We just happen to be only for women.
Yeah. Right. And that was the one thing. I was like, do I feel okay giving up men as patients, except in the public health or as partners capacity? Right. And I was like, you know what? Yeah, I could go without some
I felt the same way.
those things.
All right. So
yeah, that was my story of how I got into it. But bioethics became this theme in residency where I would continue my research sort of followed these bioethical tracks. Mm-hmm. And that's what led me to want to define my career that way.
Okay.
And I can go on, but.
Well, I mean, it's interesting because, there may be people out there who had never really thought about bioethics as an OBGYN. And I'd never really considered it. I mean, I know bioethics exists, but I haven't really seen any OBGYNs go into that. And so I think people will be interested to hear, what you do and how you got there. And so let's take that and segue into your paper, because I think it's really interesting. And you're right, it absolutely comes from the beginnings of evidence-based medicine and then moves into a question. And what I think is interesting about this question that you asked, which basically is about breastfeeding with HIV and should we recommend it or not recommend it. But we, in medicine, well, OBGYN especially, but I'm sure general medicine as well, we get stuck doing something that started for a good reason, mm-hmm. And we just keep doing it without mm-hmm. necessarily going back and looking at, should we still be doing it? This happened with the episiotomies. And thankfully, I think in most academic centers, at least, the episiotomy is not really routinely done anymore, but it is in some places. There are other things as well, though, that we see, like in New York, we have this Medicaid form for tubules has to be signed like 90 mm-hmm. days in advance, and mm-hmm. If it's 30 days, within 30 days, and whatever it is. And it was designed because people were doing unindicated, or I'm saying not unindicated, but unrequested tubules on people.
Mississippi appendectomy.
Right, there you go. And I like that. I haven't heard that one before. And
it's horrifying.
And people, and this was a response to that, to prevent women from being preyed upon, essentially. And it made sense in 1970s when it came out. But now it's 30 or 40 years later, and now what it does is actually make a barrier to women mm-hmm. getting a tubal.
Yep.
And I personally believe we should go back and revisit that, because it's having, I would say, unintended consequences, but I guess they are. They're unintended consequences of something that started out in good faith. And so what you looked at is sort of similar, where mm-hmm. When the HIV epidemic was probably at its peak, and we told women that they should not breastfeed if they have HIV, regardless of whether they had control or not, because there was a decent chance of transmission.
Well, we didn't just the history is so important. I've just become so much even more convinced of this, of how much the history of our practice and our society influences the ethics of what we're doing and the practice of what we're doing now. So we didn't used to just tell women not to breastfeed. We used to tell women to terminate their pregnancies if they had HIV.
There you go.
And we used to tell them used to tell them to get a tubal, so they would never get pregnant again. And so that's really the background context of like HIV care for, gynecologic/obstetric HIV care was what, especially once we learned that it was something that was transmissible to an infant, that was the stance. And we came such a far away from that. and then it seemed to sort of abruptly stop with breastfeeding. So I think that that context is really important to keep in mind.
Agreed. And so what you did in your paper, and I'm going to help you. I'm going to ask you to walk me through it a little bit. Is you said, okay, well, let's go back and look at the actual data, especially now we're in 2019, where we have good access to good antiretrovirals and really proven regimens now that can make viral loads undetectable for years, decades at a time. Should we reevaluate our breastfeeding recommendations? Because also in that intervening 10 or 20 years, we have really come to learn how good breast milk is for babies. And you do break it down a little bit in the beginning between developed and underdeveloped countries. And I think that most of your paper is talking about developed countries like the U.S. But certainly the calculus may be different in underdeveloped countries.
Yeah. So, we have this, what you were describing, it's really gone even beyond that we have effective treatment for HIV, because there's this new movement called U equals U, which means undetectable equals untransmissible. And there's this extensive, hundreds of thousands of years of data between couples that are sexual partners, that even with the person who has HIV having an undetectable serum viral load, even with unprotected intercourse, their partners are not getting HIV. And so that has dramatically changed the landscape, in addition to the fact that now with HIV, can be well controlled and you live a normal lifespan. So it's a completely different context. And what captured my imagination about this issue is that, actually because of similar evidence in Africa, the WHO for breastfeeding, the WHO actually recommended since 2009 that women living with HIV take antiretroviral medications and breastfeed, because they found that the children of those women who had HIV who breastfed had better survival than the infants of the same women who didn't breastfeed or had either a combination of breast milk and formula. And so with all of that kind of context, the question I set out to answer was, is this an evidence-based recommendation, or is this a stigma or prejudice-based recommendation? And so that's the question I was seeking to answer, and this paper was sort of the entree into what I ultimately have developed is this concept of prejudice-based medicine.
Okay, and so there's your question. It's a good question. What was your framework for trying to answer this?
Yeah, so the first thing I had to do was just the deep dive onto all of the evidence that's available. What is the evidence that informs the WHO recommendation that women in low resource settings should breastfeed? What is the evidence about breast milk as in terms of infant health in developed nations? Because I'm really and the paper is about the U.S. context specifically and other developed nations, because the recommendation is worldwide to breastfeed in this setting, but the exception is any high resource setting doesn't have that policy. They have the reverse. And so my first task was to sort of really critically evaluate the evidence that exists about breastfeeding and about perinatal HIV transmission, and about breastfeeding also as a women's health issue, and sort of break that down. And as I was saying to you before, my first question to really answer was, for the infant, are the risks outweighing the benefits? First we have to discuss, because the concern, of course, the theoretical concern of HIV is a harm to an infant.
Right.
And so the concern was I think the first thing I wanted to address is, does this make infants better off or worse off? And after extensively reviewing the evidence, one, I think that you can say, although it's controversial, I do believe the evidence supports U equals U for breast milk as well as for sexual intercourse purposes.
Okay.
And so we also know about the insane amount of benefits to infants from breastfeeding that we're constantly, haranguing on in every other setting.
Right.
And shoving down everyone's throat, even if they don't want to or have good reasons for not wanting to. And so in that setting, of course, it's difficult to apply some of the evidence to high-income settings, because the harms that infants face in low-resource settings related to mortality, such as infectious disease related death, like from gastroenteritis or pneumonia mainly, which we know is offset by breastfeeding. That benefit, because child mortality in the U.S. is so much lower, that benefit was sort of less pronounced. But there are a number of other benefits that were relevant, like decreased SIDS, decreased necrotizing enterocolitis, and other diseases, like potentially, mortality-causing diseases that affect newborns in the U.S., in addition to the long-term health consequences, such as like diabetes and obesity, asthma, leukemia, things that like get thrown in there. But to me, that there was like a clear mortality benefit for infants. And so I sort of started thinking about, well, there's this one risk, and on the other side, there's like the risk, I would say, of formula. Because we treat breast milk as the normative feeding method. So to do formula is an intervention.
Agreed.
But there's risks of that intervention. And in the setting of a woman with an undetectable viral load that's been consistently undetectable, I think my conclusion was that we at least have equipoise clinically in terms of that infant. And once I sort of established that, I felt you could make the argument for at least equipoise, if not that maybe infants with mothers who have an undetectable viral load probably benefit more than they are harmed. But once we had that, I sort of took that position and then analyzed it ethically from the perspective of respect for persons, like we talk about, or autonomy related considerations. I also talk about this approach that's been proposed, which is a harm reduction approach to this issue, and then also justice related concerns. And so sort of I can kind of walk you through how each of those sort of shake out, if you'd like.
Well, why don't we start with, what did you find in the evidence that is for women with a undetectable viral load, taking their medications successfully, what is the transmission rate, if you could find any data on this, for those infants?
So the biggest studies and the most recent studies have a 0.3% vertical transmission for 6 months of breastfeeding in women living with HIV who are undetectable. Okay. Now, there's some complicated factors because this evidence is not based in a high-resource setting. So the viral load data, for example, is not always perfectly matched up with the time frame. Okay. So, for example, there might be reason to believe that those transmissions that occur in that setting, maybe they weren't actually undetectable at that point.
So that will be our ceiling, I suppose, 0.3, the highest that we think it would be in a high-resource setting, like here, in women who we know have an undetectable viral load. But it may be lower than that, but the highest it'll be is 0.3?
I mean, it's certainly – I mean, I don't want to say that either, because when you think about those are clinical trials, right? And so obviously clinical trial participation may involve more control than just, the laissez-faire postpartum life of women in the U.S. now, like in the fourth trimester, if you will. So I don't want to say it's higher or lower definitively. It's extremely low to the point where it approaches the same level of elimination that we, assert with pregnancy itself. And I think that, the same things seem to apply. Okay.
And then on the other side, I should state back with that even if an infant does get HIV from the mother, these days it is not it's not a lethal diagnosis anymore. And that with proper treatment and maintenance, they could live a full life, like we were talking about before, where it's really become a chronic disease as opposed to a lethal disease.
Right. Which is kind of the frame that we sort of discussed at the outset. Right. Is this I've heard many clinicians say I'd rather have HIV than diabetes, for example. Okay. Fair enough. For whatever it's worth, Right. But yeah, exactly. And I do look at that data as well, because unlike in the settings where HIV is much worse for an infant in Africa to get HIV than it is for an infant to be born with perinatal HIV in the US, because of the resources we have. And for example, there was, from all children with HIV in the U.S. under 13 in the year, I think it was 2015 was the most recent data I had at the time, there was one death in all of those kids. And it was less than 1 in 100 child years.
Okay. So it's really low.
Really low.
Right. And then you get into your data on the breastfeeding for infants, and you already talked a lot about what the different things are. And then we obviously know there is a benefit to babies receiving breast milk over formula. Now, I think no one would argue that it's not like there's a, 50% decrease in mortality or something dramatic like that. But there are a whole bunch of little things that combine to decreasing overall morbidity for infants who are breastfed as opposed to not. And there's probably more things we're going to learn about breast milk as we're studying it more now. So then how do you go about weighing those two things? You have the benefits from the breast milk, which again, are usually about morbidity or, otitis media or things like that, as opposed to death. And then you have, on the other side, you have 3 out of 1,000 babies being breastfed who may get HIV. So how do you, when you're talking about ethically, a framework for this, how do you try to balance those two things?
Yeah. Well, just like I chose to focus on the infant first, I chose to focus on actual mortality first, because I think that's the most impressive thing that we have to really worry about, right? And it's the most clear. And so, as we just discussed, mortality even for HIV in the U.S. for a child with HIV in the U.S. is extremely low. And so I wanted to look at what the mortality was for infants in the U.S. who, as a result, risks of mortality that they might incur as a result of not breastfeeding. And like I was saying, the biggest ones that are, sudden infant death syndrome, which is, more than, it's 2.5 times more common if you don't breastfeed. Things like infection, specifically sepsis and necrotizing enterocolitis, especially in the premature infant population, actually cause mortality. And it just, even though the scale is different than in other countries because our overall child mortality is lower, I think you could really started to crystallize this idea that actually the mortality for infants of women who live with HIV in the U.S. who don't breastfeed might actually be higher because they're not breastfeeding than it would be if they were. And the really important thing that comes in here is the racial disparities. And so when you start to think about, okay, wait a second, let's think about who are the women in the U.S. who are living with HIV. And well, it's 20 times more common among Black women. And you know what also is more common among Black infants? SIDS, necrotizing enterocolitis, and other diseases of prematurity that are SIDS is by definition fatal.
Right.
So comparing, when you're comparing risks, we really have to ask ourselves, these are health risks. Is there a reason why we're looking at HIV as a risk and counting it differently than other things that are potentially equally, risky, right, in terms of, mortality? And I could really try to stake the conversation about the infant's risk in the risk of mortality causing agents. And then there's also all these other considerations about chronic diseases that they might be higher or lower risk of. And that's why, I think the easiest position was to land on the idea of equipoise. And, we know, and ACOG is always saying, okay, disadvantaged women of color, them and their infants would disproportionately benefit from breastfeeding.
Right.
And their rates of breastfeeding are disproportionately low.
Correct.
And so part of our charge as OBGYNs and other women's health/infant health providers is to narrow that gap. And so, really I start to ask, why are we treating this differently when it might be causing more harm than good? And then when you start to think about, well, what about the woman? If I can't say one way or the other for the infant, just to be safe and say, well, I'm not sure. But what about the woman? Well, women are clearly at a greater health risk if they don't breastfeed.
Yes.
And the data on this is becoming more and more compelling, not just cancer, breast, uterus, ovarian, cancer, but diseases of metabolic syndrome, so hypertensive diseases, stroke, heart attack, coronary artery disease, diabetes, all higher in women who don't breastfeed in a dose-based fashion. And then women who don't breastfeed are also at higher risk of obstetric complications from a subsequent short interval pregnancy, which can be especially bad in the case of a woman who had a C-section. So you have things like accretas and uterine rupture that are more common in those short interval pregnancies, and we know breastfeeding decreases the risk of that.
I think you made a very important point there, which is, yes, the when you're talking about the absolute number of deaths that breastfeeding is going to prevent is small. You know, maybe it's 1 in 1,000, maybe it's even a little less than that, but it's not a huge number. But also, if 3 out of 1,000 babies are getting HIV and 1 out of 1,000 of those babies is going to have a mortality, that number is even smaller than that. And I think you're right. There is this cultural, I guess I'll call it cultural or societal bias against HIV, and it still is ingrained, I think, in the at least the American psyche, probably worldwide psyche, that HIV is terrible and you should do everything you can to avoid it because it'll kill you, and it's scary. It's like a modern day boogeyman, right?
Yeah.
So it kind of blows up that
panic,
right? It kind of like makes that seem worse than it really is in our head. So I think the absolute number there is an important thing. And until you went through that, I'd never put that connection together.
Yeah, and in the paper, I mean, you could look at the paper, and specifically there's a supplementary. So this was there's so much research on HIV, it's like impossible to actually be on top of all of it.
Right.
So I ultimately made this data table that I'd be happy to, it's in the supplementary file. But it has some of the numbers, which I think just like looking at the numbers, and I walk through a little bit of it in the paper, but the numbers are impressive when you think about it, especially when you start contextualizing it with the racial disparities. But you know what you're bringing up that you're bringing up my point about harm reduction. So there's been acknowledgement of the fact that telling a woman not to breastfeed can be difficult for them, and specifically in certain cultural settings. And there began to be this awareness that, well, maybe, you know, women are breastfeeding that are just giving us lip service, saying that they're not going to breastfeed. Maybe they're doing it anyway, and maybe as a result, they're not doing it as safely as they could be if they actually had provider support. And this led to one provider in particular, Judy Levison, in Houston. She's at Baylor, to start trying to support women who decide to breastfeed against recommendations, so to use their terminology. And it's pretty amazing because they got this language, because they sit on the perinatal HIV guidelines committee, she and other people that began doing this. They got that language, the harm reduction language, added within the past year. I think it was actually just about a year ago, in maybe March or so of March of 2018, where they added language even in the guidance that what to do if you tell a woman, for all these reasons we recommend that you don't breastfeed, but what if she's going to do it anyway? And making some strides in terms of giving providers an approach to reduced harm.
Right.
And my problem with that which was great, and I couldn't be having the discussion that we're having today without what they were doing. However, my point was that is viewing HIV as the only harm that we're trying to reduce. Mm. And what is the classic use of harm reduction as a strategy for public health is clean needles for IV drug users.
Right.
And breastfeeding is not a clean needle. It is an inherently good thing.
Right. That
we think, all things being equal, all women and babies benefit from. And so to use that framework seemed inappropriate. And seemed to sort of maintain a lot of, while trying to reduce the force of a, hardline stance, and trying to make a therapeutic gap. I mean, the fact that in bold they still say, it's breastfeeding is not recommended, and if despite exhaustive counseling or, whatever the exact language is, literally they say exhaustive counseling, or a woman insists on breastfeeding despite our recommendations. I mean, that gives you an idea of how this might still perpetuate some of the same problems that having a hardline stance is. That a woman will just, tell you what they want to hear. Maybe even worse, they'll withdraw from care.
Right. And
these are patients that have a very high risk of loss to follow-up, especially postpartum. And then maybe they're off in the world breastfeeding and everything without that. And so I think we really, again, going back to the evidence, the whole charge here is that our recommendations for women need to be based on evidence where possible and informed by, ethics and reason where there's lack of evidence. And if you think that it's at least unclear for an infant whose mother is virally undetectable, and this, we see our patients many times in pregnancy, so you actually have a good sample. This is not like some person off the street. This is somebody you probably saw in high risk OB
right.
Many times. If you talk about her infant and you can't decide for sure whether you think her infant is harmed or benefited by breastfeeding, you have that state of equipoise, then the appropriate framework really is shared decision making and using what evidence we have to have a conversation with that woman and assessing her own, risk tolerance and concerns. Does she have breast cancer in her family? Well, maybe she would be more inclined to want to breastfeed. Is she, did she use IVF even though she's been undetectable for 10 years? Did she use IVF because she didn't even want to have, unprotected intercourse with her partner because, to conceive? Well, maybe she's going to say, no way, I'm not doing anything that could even theoretically increase the risk. But that's her, and that's on her, and that's her. It's like her body's her child. Like,
right.
To me, it's crazy that we would,
well, I think
tell women not to do this.
Well, you're getting into an interesting junction, and there's two things you talk about in your paper anyway. But one of them is patient autonomy, or just autonomy in general, and the other one is informed consent, which is something I've talked about a lot in this show before. And those two things go together because hopefully people make autonomous decisions based on good recommendations. But I have a big problem with informed consent because how long did you spend researching this paper?
Oh my God, years.
Years. Okay. So then how are you, I'm going to call you an expert on this topic. Right?
This is one topic I am an expert on.
Okay.
Yeah.
So then
I'll take that.
Now you have this woman in front of you, right? And you have 5 or 10 minutes, in private practice setting, right? Maybe longer in a specialty setting. Call it an hour. And you have to distill everything you know about this subject that makes you an expert to give her the information she needs to make this choice. And number one, I think it's an impossible goal because more than likely this person does not have your undergraduate degrees, your master's degree, your medical degree, your residency, or your ethics training to even have the framework to discuss the things that you're trying to discuss with her. So how do we go about really doing informed consent and allowing that woman to then have the autonomy to choose what she wants to do?
Yeah, I mean, I think this is where, one of the things I suggest is that we really need to develop tools both for clinicians and for patients to help guide them through these decisions. So that's part of the answer, is that there needs to be decision tools. I would say that you ought to have more than 5 to 10 minutes also to discuss this because this is a really big deal. And right now, the cool thing is that as a result of this work and more patients that are coming up with HIV requesting to breastfeed, and there's sort of like this wider, knowledge that this is a thing. It's like going on in other countries. Some women breastfed a child before they moved to the U.S. and Africa or wherever else, and they're like, "What do you mean I shouldn't breastfeed here, but I should before?" And my other child doesn't have HIV, and that was so important. Blah blah blah. I mean, these discussions need to be brought up early, and what we're developing now are guidelines for how to address the issue of infant feeding for women living with HIV at our medical center in the United States. So that sort of we're trying to make that framework because it's important also to have consistency across providers, and not all providers know as much as others. And so the one thing I would say is that women are experts in themselves. And so as much as I know about this topic, and as much as part of I view my job as to inform her of medically relevant information that she could use to then make a decision based on her life. And part of it of our job is to guide women to the decisions that we think are in their best interests. But that's what shared decision making is. It's a process that we engage in together. So I have just as much responsibility to learn what is important to her and what are the factors that guide her thinking about this, as much as it is for me to share the risks and benefits. And women have a lot of ideas about like whether or not they would want to breastfeed. You don't have to they know in the culture it's breast is best. And the reason why women experience it as a harm if you tell them not to breastfeed, they're not, the term that I hate is not allowed to breastfeed.
Sure.
And that comes up often. If you tell a woman she's not allowed to breastfeed, she experiences that as a harm because she thinks that, as we tell all other women, that breast milk is the best food for babies. and because she wants to be a good mom. So when you tell someone you shouldn't breastfeed or you're not allowed to breastfeed because of your HIV status, it's really like saying you're a bad mom because of your HIV status. And so I think that, having that framework is really important. And there's a shared mental model, and so we have to fill women in on, yes, what are the details, but just like we teach them, and they teach us about what it means to manage HIV and pregnancy in general, I feel like it's just more of that same conversation. And it needs to be based on them.
Yeah, I mean, that kind of, we come upon that exact question, I think, often in OBGYN. Another one I can think of off the top of my head is VBAC, where, we have people who, okay, you have a 2% chance of having a uterine rupture. And she says,
right.
Okay.
Well, what does that mean to her, right?
Right.
What does she know about what a uterine rupture is? Like, how could she even,
Right.
Like, that's informed consent is kind of nonsense in that regard.
It is. I mean, you can say, okay, so two out of 100 people, just like you, will have a uterine rupture, and a certain percentage of those people will end up with something catastrophic. And she says, okay, but I still want to have a vaginal delivery. And that goes into what they were talking about with the breastfeeding before was, okay, so now what do I do for this woman who, against my recommendation, is going to try to have a vaginal delivery? And we've had a few cases like that over the years at Stony Brook. We had one lady with 3 prior C-sections who wanted to have a vaginal delivery. And that everyone got very up in arms about that. To which I said, well, she's been counseled about the risks, and that's what she chose to do. So what are we going to do? Right? We just document well. At the end of the day, we're not going to not take care of her.
Right.
So, do the best we can for her.
Brings up a really good point, because I think a parallel issue, we used to do C-sections to prevent perinatal HIV transmission.
Right.
And why did we stop doing that? Well, we realized that with women who have a low, not even undetectable, but women with a low viral load, the marginal risk to the infant from a vaginal delivery was not justified by the harm imposed on the women.
Right.
From having a surgery that was not indicated.
Right.
Or indicated for that purpose. That tiny difference for the baby wasn't worth causing the harm to the woman. And that's like not even the same argument that I made, where I was like, first, let's talk about the baby.
Right.
Like, we're talking about baby only first. And then we think when you add the woman to it, it's like, well, actually, this is maybe harming both of them more than it's helping anybody. And then it's like, who is that serving? Like the providers, their own, like, this is like, you have to think about the context of a woman with HIV, like, who, is carrying a pregnancy. Like, that's like her context is like of the whole thing.
Right. Well, I think that gets into something that I've been thinking about a lot recently. I've been trying to come up with an episode about it, but I've been having a hard time making something interesting. And that is about the decision to do nothing. And in this case, it is a decision not to do a C-section for these women. And sure, I mean, if you do a C-section, you're going to prevent, I don't know, X number of babies that get HIV, right? Whatever that number be. It's very small now, it's actually not detectable, but there's still some. And then the decision to do nothing, well, what does that get you? Well, it gets you vaginal deliveries, and you get rid of all the C-sections, but we, as humans, don't think that way. We think through the positive consequences of doing something, but not the positive consequences of it not doing something. And so we apply it to a lot of things, CAT scans and blood tests and all this stuff, right? But I want to reframe the decision to not do an intervention as the decision of an active decision.
Yeah, you're intervening against OB/GYN's behavior.
Right. And that has its own, sets of pros and cons or risks and benefits. But I don't think at least in my head, I'm starting to try to change how I compare those two things as two active decisions as opposed to an active versus a passive decision.
I think you and I may have talked about this in person. There was recently a speaker who's interested in sort of some aspects of data, and especially areas in medicine where we have too much data, like genetics and EFM were
right.
things that she spoke about as specific examples. And her whole position was, that we should have more guidelines for how to enable OBGYNs to do intermittent monitoring and collect less of this data that, they don't know how to deal with or whatever, or that makes them more likely to do a C-section, even though we know that the benefits on a societal
right.
level are not, are not that we're causing more harm than good, right?
Right.
And to me, I was like, both practically and ethically, I don't think, like I understand where you're coming from, and I agree we do a lot of things that are not indicated. But I never see EFM, at least some version thereof. It might change we might be following the EEG instead of the heart rate or whatever,
right.
But like we're never going to de-implement EFM.
Agreed.
It's not happening. And so my kind of response was like, and in general, data is increasing in every area of our lives. That is like a losing battle to fight to make less data. What we need to be fighting is how to interpret that data better. And it also seems absurd to me that we're using the same basic framework for interpreting EFM that we were using when it was developed or first implemented,
right,
like over half of a century ago. That's absurd to me. And I loved this term of my own. I was like, this is so clever. I'm like, EFM doesn't cause unnecessary C-sections like people practicing obstetrics do.
That's correct.
And so, to focus on how our stewardship of data was sort of my plea, and the way we can maybe do more sophisticated analysis. And also, I think about almost like from a virtue ethics perspective, seriously, I'm always talking to residents about my general disposition towards the EFM, and that I'm aware that it's there, but I purposefully ignore it. Mm-hmm. Because it's so obvious, like when you have one patient laboring, like, and everyone's bored and they're just like looking at every decel,
right.
And it's like, like the Wile E. Coyote, like there with the scalpel, and like everyone's putting their bibs on, and I'm like, just stop, like she
right.
could be laboring at home, for crying out loud.
Right.
Like,
stop looking at it.
This patient is like totally appropriate to have like a home birth, so like, not that I'm saying she should, but I'm just saying like, the fact that you're looking is making it hard not to do something. And I always love that expression, don't just do something, stand there.
Yeah.
I think that's a fascinating topic.
It's a challenging thing to do. But we actually have a NIH grant at Stony Brook now looking at using machine learning on EFM to see if two things. Number one is, can they come up with better criteria than we currently have?
Of course.
And then
it wouldn't be difficult to do.
Probably. And then second is, can we actually abstract the EFM away from us into a computer, essentially, that just spits out, bad, intermediate, and good. And then we can do with that as we wish, as opposed to staring at the strip the whole time. Now, that's far in the future, if ever, but it would definitely get us away from staring at the strip the whole time.
Well, yeah, it could have practical benefits just in terms of how you spend your time on the unit. But, it's so interesting, right? Because the question about machine learning, how can machine learning do better if machine learning is learning from humans and we've done crappy? Well, so how does it not learn the same patterns that we learn?
Well, in this particular case, they're just basically feeding it strips and outcomes, and they're asking it to figure out, what correlates to the outcomes. That's it. Right. In a huge data set. So we're not, I'm not doing the project, but my understanding is we're not feeding it with any intentional bias. Now, there's probably unintentional bias in there, but whatever.
Yeah, those are the most difficult to eradicate.
Aren't they? All right, well, let's bring it back around and finish up with your conclusions here. So after doing your risk-benefit analysis, your ethical analysis on baby and mother, what did you come up with? So,
I came up with basically the view that given the benefits or potential benefits of breastfeeding, and for both infants and women, and the extremely low or very low risk of perinatal HIV transmission with an undetectable viral load, that women who meet that criteria should have the option of breastfeeding. And that, the charge was upon us as a healthcare sector and providers to support her in doing what she prefers. And that really this should be for that patient particularly, it should be a woman-guided shared decision, and that we almost shouldn't tell them, that it's not recommended. Now, I think that we need, and I think that that's especially important, again, given the equipoise for infants and given the health disparities that sort of exist in this space. And so one thing I think that could be really helpful, for example, is, when we have long-acting heart medications, because postpartum period is, there's concerns about adherence.
Sure.
And it's a stressful time. Well, it would be great if you can give a depot injection, and those medications exist.
Okay.
And we really, I think, should be advocating for them getting approved in breastfeeding ASAP, because they could be total game changers. If, imagine you don't have to worry about pill-based adherence. They really just have to show up every month or whatever it is for their injection. And you know that they're getting their medication and therefore will maintain an undetectable viral load.
That's fantastic. I didn't know that
total
existed.
Game changer.
Yeah.
I mean, those medications are being, in clinical trials now.
That's crazy.
But I think that that's important. And I think that, in the interim, having decision tools to inform clinicians, what are the things that make a woman a good candidate? What are the things that make her not as good of a candidate, in terms of balancing the risks and benefits for that infant and for the woman herself? That's kind of the conclusion that we reached, that I thought that should be, that the option to breastfeed should be included instead of the willingness to support breastfeeding despite being told not to.
How was this received in the HIV world?
I mean, I think that it was timely. I think that it's coming up more and more now. I've had more and more, like I said, I'm part of this working group in my hospital, at Hopkins, where we're developing guidelines, as we speak, we're developing guidelines for how to handle this issue. Whereas before a few years ago when I was bringing this up, they were like, there was a hardline stance. So there's a movement, and people are starting to question whether U=U is appropriate for the breastfeeding context as well. So I think that the commentary sort of echoes a lot of that. There was support even in the commentary for this approach.
So you think that the guidelines are going to change?
I do.
Good.
Yeah, I do.
That's great.
Yeah, I think it's. I think that we should not practice prejudice-based medicine.
Well, I don't think anyone would disagree with you on that. Well, getting there is difficult, but
yes, yeah.
You personally have to recognize your own prejudice,
right? And I mean that was really one of the goals I hope to accomplish through this paper by going through it is thinking, really getting each individual to think, what if this was me? Would I want to breastfeed? What if this was my friend or my colleague? Would I think that it would be appropriate for them? And then just really start thinking why am I recommending against it for other women?
So I have one more question for you.
Yeah.
Right. This paper was published in the Journal of Law, Medicine, and Ethics, which seems appropriate. But reading the paper, I'll tell you that this could have easily been published in, the Green Journal or the Gray Journal.
Yeah.
So why did you guys choose the ethics journal as opposed to a OBGYN journal?
Well, first of all, it got rejected from 3 other journals.
Oh, okay.
Yeah. I mean, which is just, this was it's very interesting. I mean, this was an extremely difficult to publish paper, even though there was, since its inception, there were people that, the paper itself hasn't changed.
Gotcha.
But it's extremely controversial to suggest, even, how dare I suggest, that women in the United States would breastfeed with HIV when you could give a baby HIV that way. And the response to that really dictated my choice ultimately to aim it towards this journal. I mean, the reason I actually wanted a more general journal, even beyond OBGYN, because this doesn't just involve OBGYNs.
Fair.
This involves, public health. This involves, pediatrics, infectious disease, medical communities. I mean, there's a lot of different, providers and stakeholders that I felt like should be part of this discussion.
Agreed.
And that was why I was seeking a more general audience. But I was finding that the general audience, even if I would have, revise and resubmit, for example.
Right.
And then the 2, they add a reviewer and the 3rd reviewer says, oh, no, this is unconscionable.
Right.
Or they didn't really, get it.
Sure.
They're just so up in arms about the mere suggestion, which kind of spoke to my theory, which is that this is not really an evidence base. This is emotionally like fear of HIV, and stigma and moral panic about HIV based healthcare. And I think we found an audience in the law, medicine, ethics community that was sort of more willing to have this discussion.
Makes sense to me. Well, I say the other three journals that you submitted it to, they lost out.
Thank you.
And I'm glad that we were able to sit down and talk about this, and hopefully my listeners will go out and look at this paper, and I'll put it in the show notes, obviously, along with a commentary that was also there, because I think it is important for, even if you don't see that many people who have HIV in your private practice or even academic practice. We have a few at Stony Brook, but not a ton. I think the overall method of going about looking at the question can inform other things that we do. And it also, I think, does a little bit to pull back what you said about the panic about HIV, and to say, you know what, maybe it's not as bad as it was 30 years ago, and that is ingrained in our head. We should start looking at it as something else. And so I thought, just for those reasons alone, it is a great article to read. And also you get into the ethics stuff. I wouldn't... to me, it was understandable, even though I really don't have a background in ethics, except for what I did in medical school. But it was to me, I could follow your arguments, and they made sense. And it was like, I see how I could apply that, like I said, to VBAC. And I'm sure there are other things that I can apply similar reasoning to. So I recommend everyone go read this. It's there for you to read.
The one context I would invite other providers to think about this work as applying to breastfeeding specifically in the setting of substance use. And so you might not take care of patients with HIV, but you definitely take care of patients who use substances.
How'd you know?
Yeah, right? I mean, especially marijuana.
It's everywhere.
And other substances, and think about whether you're telling women that they shouldn't breastfeed in that setting or discouraging women from breastfeeding in that setting, and whether it's appropriate, and kind of you can use the same, like you're saying, use this same way of digesting the issue and the evidence, and then looking at the different considerations to reflect on your practice and whether maybe you're imposing more harms unintentionally with good intentions, maybe imposing more harms than you're benefiting.
Absolutely. So yeah, it's all going to be in the show notes. Guys can go check it out. And then if people want to delve further into this, bioethics and OBGYN, is there any place we can point people to go read more, or people that they can talk to?
Well, anybody can reach out to me. So there's about 5 OBGYNs that are, professors in this country that are OBGYN bioethicists. I hope to become the 6th one.
Okay.
And I am working on starting a blog.
Okay.
So that would be, I would say, the best. I mean, there really isn't too much of a specific forum for these kinds of discussions for people in our field yet, but I'm working on making it. So stay in touch with me, and hopefully we can circle back with like a better answer, but I'm working on a blog for that.
All right, fair enough. So in the meantime, if it's okay with you, I'll put your contact information in the show notes, and people can reach out to you if they have questions, or if they want to get involved somehow and they have interesting things. You can guide them to the same path you're on. Yeah, thanks. All right. Well, Dr. Mariel Gross, thank you so much for coming on and walking us through this paper, and actually a lot of other topics as well. Really, the pleasure was mine. It was very, very interesting. So thank you. You're welcome. Thanks.